there was one of the videos I was trying to find. That was the one I was actually trying to find. At the very end, the very last one was similar to that last one. This guy comes up and he's like, "Rah!" And all of a sudden, they were all playing basketball, and all of a sudden, some dude walks over and grabs a gun, and he's like, "No, no, no, man! It's a joke! It's a joke! It's a joke!" Okay, here we go. This is the most important thing. The absolute exact questions to ask your patient. They'll give you a meaning of life. Oh, see, I'm going straight for it. 10 minutes over here. All right. So, what it is, I broke this down into a couple different topics throughout this thing. So we're going to start off with chest pain patients. So every chest pain patient, you're going to start off with, "Hey, how's it going? What's your name?" Right?
Dustin.
Dustin. Hey, Dustin, what's going on, man?
I just feel this pressure in my chest.
All right, so you got your chief complaint, right? You're not there because dispatch sent you to respiratory distress or anything like that, so that is not your chief complaint. When you guys write your charts, the chief complaint is that right there. Initially what they tell you, okay? That's your chief complaint, and then it may change halfway through your assessment, right? Right?
Yes.
Yes.
Do you get more information?
Yeah, you get more information. It's like, oh yeah, I got this chest pain. Okay, yeah, actually, it's just, something else is bothering me more. But I do, like I said, the chest pain word, it gets a lot more bells and whistles coming. Okay. So OPQRST and sample history. You do this on every single patient. If you do this on every single patient, you will be very successful in your career. The big problems that people struggle with is they hit their onset, right? Onset, provoke, and then poof. They get a couple answers, and then they start down this wild goose chase, right? You got to work on finishing out your OPQRST. So, everybody knows OPQRST from your basic stuff, right?
Yes.
So, what in OPQRST do we want to know in regards to chest pain? Start at the beginning. When did this start? Why is that important to us as paramedics? What can we differentiate between?
If it's
So
acute.
it's like musculoskeletal
Did you
or...
just eat food? Did you tell him what was he doing?
We're not to like the other stuff around. We're going strictly based on time right now. We're looking at time, onset. When did this start? Right? Like, so when did this start and what were you doing, kind of thing. So with chest pain, is it different if we say I've had this chest? If they say, hey, I've had this for like 3 weeks,
Yes.
Yes.
versus hey, I was out mowing the lawn and I developed this chest pain.
Yes.
What does that tell you?
Be
More acute.
musculoskeletal or...
Could be a clot, something
So let's
that's
say
blocking
it's
it.
something that I was out mowing my lawn and it started hurting now. Cardiac related versus non-cardiac related.
Sounds more
Leaning towards
cardiac.
cardiac.
Yes.
Why?
Because
mowing the lawn is
Because we're doing
stressful on
something,
the
right?
heart.
Exertional, right?
Mhm.
Increases oxygen demand. Okay, so boom. Okay, so that's our first red flag for cardiac, chest pain, okay? Provoke, right? What kind of provoke questions?
Does movement make it worse?
Oh man, that is super vague. Super vague. What do you think you're gonna get the answer every time?
no.
No, nothing makes it better, nothing makes it worse. So what do we do as paramedics?
Ask what they did when it started.
We dig deeper into that provoke, right? So what kind of things do you think are gonna lead us towards cardiac versus non-cardiac?
Did it get better when you sat down?
Oh, yeah. When you were done mowing the lawn and you came in here and sat down, did the pain go away? Okay? Does it change if you move your arms? Okay? Yeah, it hurts when I move my right arm. So what do we think? What are we thinking then? It hurts when it moves my right arm. It makes it worse.
Muscular.
Are we thinking cardiac or non-cardiac?
Non-cardiac.
Are we completely ruling out cardiac?
No.
No. But now, we were up here with our O. We were up here high, like yep, cardiac, cardiac, cardiac. And now we've transitioned. We're like, we're gonna bump down a little bit now because now we're getting some stuff that's non-cardiac questions, right? So does it move? Okay. How about if you take a big deep breath? If you take a deep breath, does that pain change? Yeah, it makes it worse. Are we thinking cardiac, or are we thinking maybe not cardiac?
Maybe non-cardiac.
Okay, so now we're heading back away from the cardiac now. Can we throw cardiac out though?
No.
You can never throw it. Anytime anybody ever says they have chest pain, you can never completely throw it away. But what you can do is you can slowly start moving slowly away from it. It will always be out there in the back of your mind that because if people present differently, you have all kinds of different presentations, so you have to do your full cardiac workup. But you're starting to think, maybe there's something else going on, okay? So we'll back up now. Yeah, nothing changes, nothing makes it better, nothing makes it worse. I was out mowing my lawn, it hurts still just as bad as it did. No pain when I move, no pain when I take a deep breath, no pain when you push on it. Are we thinking high index? Alright, Q.
Quality.
How do you ask somebody what the quality of their pain is?
Can you describe it?
Can you describe it? I don't know, it hurts.
Is
Which is
it
the best,
a
because I
sharp
love being
pain
a
or is it
patient for
like
you
a
guys. When you guys
dull-
ask that, like, hey, can you describe the pain?
Yeah,
It hurts.
but you gotta start with that.
Can you tell me where it hurts? Can you point right where it hurts?
Okay, yeah, hurts right here.
Because you don't want to,
From no
Is it like a
pain
sharp
till
stabbing
worst
pain or is it like a dull aching
Oh,
throbbing?
So now you're gonna start throwing out crazy random words out there that are all over the place, right? So what is the thing that you are suspecting you're going to hear?
It's
What do you want to hear if this is cardiac?
An elephant sitting on your chest.
Okay, you're listening for crushing, heaviness, pressure. You're listening for those words, right? So what you don't want to do is you don't want to volunteer those words. What you want to do is you want to volunteer other words in an attempt to rule out all the other stuff very quickly. So is it a sharp pain? Is it a stabbing pain? Is it a tearing pain? And they're like, no, no, no. It's like, does it feel like somebody maybe like punched you in the chest? Oh, okay. Like maybe like something heavy? And yep, mm-hmm. So then it doesn't just automatically, you're not leading them right away. Like you're giving them the opportunity to sell you on, yeah, this person has legit crushing chest pain, right? Some people will just come straight out and be like, yeah, I have this heavy crushing chest pain, substernal in nature. It's like, whoa, are you like a medical person or something? They're like, no, I watch ER and all those medical shows on TV. Okay, so you don't want to just throw out what it is you're looking for. Same kind of thing like if you're looking for a AAA. Somebody has a AAA. The thing that the presentation is either chest or back tearing sensation. I'm never going to say tearing to them until I have already given them the crushing pain and given them all those, right? So I always give them that as the last option after they've already said no to the other ones. Okay? Because as soon as you start leading people, they're going to start agreeing with you, thinking that that's going to get what you want to hear. Okay? So you just don't want to just be another, hey, okay, so you got this substernal chest pain, crushing in nature, right? Yeah? Okay, is it probably a 10 out of 10? Yeah? Okay. All right, yep, you're having a heart attack, we got to take you to the hospital. Right? That's not how we do it. We get a little more investigative, we talk about it, we talk about the questions that we're going to throw out there to them, and then we work through there. Radiate. Where do we want to know if it's radiating?
Left side.
Back.
Testicular.
So when you ask somebody, hey, does the pain radiate anywhere? Most of them are looking at you like, what do you mean?
Do you have pain anywhere else?
Does that pain in your chest, does it move? Does it move up into your shoulder, into your jaw, into your neck, into your arm? Yeah, it's into my arm. Okay, just one? Both arms? So what I do is as soon as they start to give me those textbook presentations, I try and bluff them a little bit. Be like, oh, yep, it's radiating down my left arm. I'm like, oh, how about radiating your right arm too? If I get a yes over here, I'm like, ooh, does it radiate in your right leg? And they're like, I think I might feel it a little bit. I'm like, okay, now we're getting some progress here. Okay, so what am I immediately doing?
Ruling it out.
I'm starting to get those rule out things. I'm saying, okay, this guy's trying to go through. So now I'm going to start going into more creative questioning on some of my other stuff to try and figure out, is this person legit with their, when I say legit, like a legit cardiac emergency, or is this something else that's going on? Okay? Severity. What do we use?
0 to 10.
0 to 10, right? How many people hate to give that number? I don't know, it's an 11. Or I don't know, I can't give you a number. And then like just 2 days, like yesterday, I watched a probie like ask this guy like 3 times, like he's like obvious in distress, and he's like, so what's your pain? He's like, I don't know, it's bad. He's like, well, I need a number. And he's like, a number of what? I don't understand. He's like, I need a scale, 1 to 10. How bad is the pain? He's like, it's bad. I'm like, so finally I walked over to him, I was like, I'm gonna guess that's above a 5 and below a 10, somewhere in there. You can probably just exclude it from your documentation and say, bad, right? There will be time, like, you don't have to have an absolute number every single time, okay? Like, it's not one of those things where it's like, if they got pain, they got pain, right? It's like, you will recognize someone that is in obvious distress versus somebody that's not in distress. Does that make sense? I've seen people push that number, trying to get that number, especially in the hospital, we'll do that a lot, okay? Time.
How long?
Has this ever happened before? Or when?
Like, how long ago
So we'll
did the
get
pain
into that, has
start?
this ever happened in just a sec, what?
Like, how long ago did the pain start?
So that's a little bit on the onset,
Okay.
okay?
Does it come and go in waves?
There you go. So in relation to the time, like what is happening with this pain? Does it come, does it go? Is it always there? Is it always sharp or is it always heavy pressure the entire time? Or does it let up? Is it peristaltic in nature? Like how is this timeline from the time it started? What has it been doing during that time? And if it's been going on for multiple days, you want to know, okay, what has happened during those days and what caused you to call today? Okay? Yeah?
So when you're asking these questions, are you starting with a diagnosis in your mind and then you're asking questions to confirm your diagnosis or take you down a different path, or are you just getting all of your data and then at the very end deciding this is what fits my data?
That is an awesome question. What do you think? What would you do as a paramedic? Because I'm not going to tell you how I do it until you guys think about how you guys are doing it.
Well, I think paramedics should do it different, but from a basic point of view, you ask all your questions for your data and then at the very end you come up with a diagnosis.
All right, so you are correct in that a paramedic should do it differently. So yes, somebody tells me I have chest pain. Boom, I immediately go to worst case scenario. Okay? Worst case scenario in chest pain is either AAA or somebody's having an MI. All right? So I immediately go to those, and then I work my way back.
What's
Okay.
AAA?
Aortic aneurysm, abdominal aortic aneurysm, and we'll hit that a little bit later here. And so you immediately, because you don't want to downplay stuff, right? So you immediately think, boom, this guy's having a heart attack, got chest pain, I'm going to go down all of my cardiac questions, okay? For me, the first question I ask after somebody has chest pain, the very first question I ask, they're like, hey, what's going on? Hey, I got this chest pain. I'm like, hey, do you have any shortness of breath with this? Okay? Because if they don't have shortness of breath, then that leads me more down the cardiac stuff. If they say, yeah, I got some shortness of breath with this, I'm like, okay, I got like 5 different directions I can go now, okay? Because you can have arrhythmias that are causing shortness of breath, you can have lung conditions that cause chest pain that cause shortness of breath. So you have this additional factor that is just like, boom, here is a whole bunch of different directions. Now I gotta rule out each one of these to go, okay? But where if they say, no, I'm not short of breath, okay, cool. I can eliminate some of those lung conditions, pleurisy, stuff like that, then I'm just like, okay, more than likely that's not what's going on. All right, whew. So we've made it through a PQRST. What do you guys think? You think this person's cardiac related emergency so far?
Which person is it?
We're going back to the one that we had rewound, that nothing had changed.
So, like you said, quality.
So do we want to go back and ask a few questions so we can figure out what patient we're at?
Yes.
All right. Ask some questions.
This is the one where the lawnmower.
Lawnmower.
correct?
We're at the lawnmower.
Came back in and sat down. He
Yes.
said that the pain did not get better when he sat down.
Correct.
Quality radiates. Does it radiate up and down his arm? Or
Yeah, it's in yes.
Okay, it radiates.
It radiates somewhere.
On a scale
Do you
of-
want to know where?
Yeah.
Okay. So where?
So does it? Do you have pain in your arm or in your jaw?
Yes.
Does it go down? Do you have pain in your arm?
Oh, there we go.
Your left
See?
arm.
See, so now you're gonna learn some of my scenario-based
Yeah.
stuff. It's like, all right, so you want specific answers? Ask very specific questions. Don't throw a whole bunch at me because I'm just gonna be like, yeah, one of those, but yes. And so I'm gonna try and mislead you in order to keep your history taking on track. So yes. So now what was the
So
follow-up?
does it radiate down your? Where does it hurt additionally, other than your arm? I'm butchering this because I'm on the spot.
Oh, boy.
So it radiates in your left arm.
Oh, yes.
Okay. Does it hurt anywhere else?
Hurt anywhere else?
So you got your.
Does it hurt in your right arm
Does
too?
it hurt your right arm too? Is it hurt
No, no, I think it's just kind of my left
How
arm.
about dropping?
All right, coming over here to, let's see, 1, 2, 3,
Good.
4, 5. Table 5. You guys are up. I'm gonna start calling on tables. You guys better be ready.
Let's do it.
Maybe we should split this table because there's kind of like a bunch of you there. And, table 5, what do you guys got?
What's your opinion on the skill?
It's bad.
Can you describe that thing for me?
Yeah,
Is it
feels like paint.
sharp or dull?
No.
Does it come and go?
No.
You said is it sharp or dull? Is it sharp?
Is it sharp? No.
Is it dull?
No.
Is it?
Do you
does it
read-
feel like
It's
it's
paint.
crushing?
It's paint. Is it what?
Does it feel like it's crushing
No.
your chest
No.
or pushing?
No.
You feel like you have a heavy weight there.
I don't know, maybe.
Is it hot? Does it burn?
I think that was a yes.
Does it hot, does it burn? I mean, it's warm outside. I haven't been burned by the sun recently, so I'm gonna say no.
It's important that you, if you can describe the actual.
You know, it just really hurts, okay? It just really hurts.
Maybe on the
They're ripping, tearing.
So you can see when you start digging into these questions and you want an answer to something, and you keep asking the same question over and over, what's gonna happen to the patient?
You're
They're gonna get
irritated.
They're gonna get irritated. And do you think they're gonna be happy with you?
No.
Do you think they're gonna shut down and just say, you know what, I need somebody that can really take care of me? You go
Someone
stand
else.
outside. Like, that's in some of the scenario world that I'll play with you guys. I'll be like, can I call 911 again? Can I get a different crew? Like, when you guys start struggling, I'll be like, "Doot, girl, yes, I need a different ambulance here because this crew is really bad. They don't know what they're doing. All right? So you don't keep prodding, you don't keep pushing, right? If it's bad, you just go with it and be like, okay, move on. All right? So what are you thinking? Are we thinking cardiacs so far?
so far.
Yes.
Whew, yeah. So far, I'm thinking there's something maybe going on here. Sample history.
Wait, I'm sorry, I have a
Oh, we're
question.
going back. Yes.
I have a question. So you're talking about just moving on when they're getting frustrated, and I can see how you could do that with getting a number scale of pain.
Mm-hmm.
But in terms of some of the other answers,
Oh, do you want to bring it? Go ahead, keep pushing.
I
We
don't,
can
I
keep
know,
pushing.
I'm wondering at what
I mean, I
point
might
you
need to
just
take my-
stop and you get vitals for your actual confirmation.
Oh, you're getting vitals while you're asking this.
Yeah, similar.
So that's why you're able to just move on.
Yeah. So as you're asking, so
Yeah.
as the paramedic, the vitals are something that it's a multitask thing. Either you have a crew member that's getting vitals for you while you're asking, or hey, I'm gonna throw this blood pressure cuff on you. While that's pumping up, while we're doing this, you're talking, you're multitasking. So all of that is getting accomplished all at the same time.
Right.
Does that make sense?
Yeah, so when you're talking about quality of pain and you're trying to get data on whether or not this is cardiac or something else, and they're not giving you a definitive answer, you turn to your vitals and go, okay, I can see there's not a problem with your cardiac.
I'm sorry, I was knocking on the door. I missed
Yeah,
this.
I saw the whole dead looking
Yeah.
around.
Blacked out for a split second. Blacked out for a split second. So what was it?
typical patient?
Yes, yeah, so yeah, see, so I quit checking it out. I
Full
quit.
picture.
So say the very end of it again?
I'm just wondering at what point do you get to choose, like, when do you need to push the issue of getting information on what the heck is actually wrong versus just saying like, well, I see on my monitor that there's nothing wrong with your heart, so I ruled this out.
So you'll never get to that point where if you look at the monitor and you can say that there's nothing wrong and somebody has chest pain, because you're very limited on that. And so you will never really get to that point where you can totally 100% move on, but it's something that's like, okay, well, I'm not getting what I need from you, so I'm gonna try something different. We're gonna ask different questions, and maybe loop back around to that question a little bit later. But what you don't wanna do is just continue to push, continue to push, continue to push on the same thing if they're having a hard time answering, or if they don't want to answer. Because you're gonna go on patients, but they don't wanna answer a single question. And finally, at some point, you're just be like, so do you want our help, or would you like us to leave? It's like, we're here to help you, but you gotta help us help you, and you gotta answer some of our questions. And usually if you get to that point, it's either, yeah, out of the room, yeah, goodbye, I don't need you, or they'll break down and be like, oh, okay, sorry, and then they'll start to engage with you again. Okay? So then when it comes down to your vital signs and stuff like that, it's like, you're getting your picture along with your OPQRST, but but when it's all said and done, you're not doing anything yet until you have your entire picture,
Got it.
okay?
Yes.
All right, so back to that sample.
How often do you get into a situation where you obviously work with your crews that you've been, I would assume with for a relatively long time? I mean, you can
Yeah.
have maybe come in here and there, but your crews are pretty well in tune with each other.
Yeah, give or take. I mean, so the cool thing with us is we have such a large group and we have so many overtime availabilities that you're constantly working with new people. Hey.
My point to the question
yeah.
is, like, if you're working with a patient and you're having obviously a rough time, I'm sure there's some of those subtle clues that you guys have learned from each other. It's like, okay, I'm just gonna alter myself into doing this over here, and this person's just gonna come right in without really skipping a beat and start asking questions, or just flat out, can you take over, sort of deal.
So you never really go to this, hey, can you take over
Correct.
mode, because then they hear you say that and realize, boom, they're winning.
Yeah.
So what you want to do is you want to basically be like, your crew, yeah, so you are going to have that moment where it's just like, you just kind of transition out, and the other person kind of transitions in. You give them a little look and be like, I don't know where to go from here. Like, I'm accomplishing nothing.
Good cut back.
Yeah, and then there will be other times where it's like, so say Mark's talking to me and he's doing the patient interaction, but I'm totally engaged, as a patient, I'm over here answering and talking to Dustin and stuff. So then it just kind of, everything kind of transitions over. It's like, all right, Dustin, you're in charge. Yeah, it's like, hey, and then you just do a little
Yeah.
switch and now Dustin's the guy. It's like, oh. So that's why, like, as you guys rotate through and be like a tech versus a non-tech, when you're not teching and you're not the person in charge, you gotta be engaged and paying attention to what's going on, because there may be that time where something flips the switch and
Yeah.
you gotta swap spots. So, you guys got all good, rhythm stuff?
Now we're not paying attention.
Johnny
You guys are checked out. I mean, all the most important questions ever, and we got EKGs in front of us, and it's the first introduction to EKGs of all that stress. Stress.
See, throw that in. This
Yeah.
is
So if you'll look on the third page, that is the EKG that comes back up. No, I'm just kidding. Okay, so sample history. S. What are you looking for on patient cardiac?
Do they have shortness of breath?
Any dysrhythmias that we haven't read yet.
So let's start with the first half of signs and symptoms.
Are they-
Signs? What signs?
Are they pale, sweaty?
Pale, cool, diaphoretic, right? You got a pale, cool, diaphoretic person that is complaining of chest pain,
Boom.
flags are going off. Like warning beacons, hey, we gotta be ready, okay? Anybody that's pale, cool, diaphoretic, most of the time they're sick until proven otherwise. Either they just got done running a marathon or something crazy like that. But most people we go on haven't just run a marathon, right? They're usually older population, cardiac related. So yeah, pale, cool, diaphoretic skin, big red flags for us. Okay, what else? What?
I'm sorry.
There we go.
I get pale, cold, diaphoretic when somebody sticks me.
Right, right? So it's because your body's trying to react to something, right? Something that it doesn't like. Same kind of thing with chest pain. It doesn't like having chest pain, so it's gonna try and react, okay?
Mentation, even.
Mentation, so if they're sitting there, if they're tracking you, that's a good sign. But if they're just kind of zoned out and,
Focused.
hey, woo, hey, like as you're approaching them and there's nobody home, okay, another potential sick person, right? All right, so then we can get into some of those symptoms, the shortness of breath, chest pain, lightheadedness, dizziness, nausea, vomiting, all red flags, right?
Yes.
I was wondering, geez. Okay, allergies. Important?
Yes.
Not yet. I got more important things to find out before I find out allergies. Okay, we'll get back to the allergies. Medications.
Yes.
Yes.
I think I've pretty much ingrained that into you guys by now, right? About how important the meds are and how important they are to recognize what those meds are. So I actually am on atenolol and nitrostat.
Ooh.
What does that tell you?
You already got cardiac, she's diet.
Cardiac history, and what kind of cardiac history?
Yeah, angina and probably hypertension.
Okay, So angina, hypertension, rate-related things, because it's a beta blocker, so we can have multitude. So this chest pain can be caused by all kinds of different stuff. It can be too fast, too slow, or legit ischemia, infarct, right? So medications are huge. P,
That's medical.
past medical history. Basically, if you know the medications, you could find out this. What additionally would you want to ask me?
You ever experienced this before?
About medication or past medical?
Past medical history. Oh, sorry, I pushed at the point at the end. P, on the P.
Has this ever happened before?
What?
Has this ever happened before?
Oh, you know what? Yeah, it has.
How long ago?
Oh, like a year and a half ago.
What
Is
did they
this
do for
the
you?
same or different than the feeling that you had before?
It's the same.
And what did they do the last time, Melissa?
They took me to the hospital.
What was it?
What do you mean what happened? They took me to the hospital. I just told you.
What did the
Did you get a
doctor's
diagnosis?
do once you got?
Diagnosis. I don't know what that means.
Did you hear
Did they
any
know
word?
what's wrong with you?
Yeah. Well, I think so.
Do you remember what it is?
They did something up in my heart.
Remember what that was?
Some sort of stent thing? An angiograph or gram or rheography or something like that? Does that sound right?
Yep.
Okay. What's that? What kind of picture are you guys getting here?
Previous heart block.
You've already had occluded.
Right? So there's something that's already happened, right? So in that past medical history, you want to know, it's like, okay, exactly that. Events of relation to this, like, has it happened before, and then also, like, do you have cardiac history? Like, it's okay to say, have you had problems with your heart before? If so, what kind of problems? It's like, oh, well, I had a cabbage back in 1998. Oh, everybody know what a cabbage is? Coronary artery bypass graft. So they had a bypass. So then the next thing you want to know is like, okay, how many vessel bypass was it? And then they're like, well, it was a 4 vessel bypass. How many vessels are around the heart? Not a lot, right? Like when it comes to the big vessels. So if you say they had bypass 4 of them, that's a big deal. It's like, okay, you were really sick back in 1998. Now you've had 20 years, 30 years, 40 years to get sick again, right? So what's happened between 1998 and now? I guarantee you there's some sort of cardiac something that's happened between here and there. So this is where getting that timeline together, figuring out what's happened between here and there, what the recent treatments have been, what the recent conditions have been, and then what they've done for it. So, all right, so, also, additionally, when I ask somebody about past medical history, how do you think I ask someone past medical history? Hey, hey, what kind of past medical history you got?
Had ingrown toenails in college.
Those are bad deals. Those are really uncomfortable. I hate those things. You ever have to have surgery on those things?
I did.
Yeah. Put the whole acid thing on them.
Yeah.
You wanna narrow it down to
Oh.
the system you're looking at, and that you.
Not even
you're
that.
concerned with.
No, because there's other systems connected to the heart that you want to know about too.
You have any heart problems? You have any problems with your lungs?
Yeah, I do have heart problems. Yep.
Would you ask when they went to the doctor?
We haven't asked that yet.
So would you?
Uh,
For the medical history, would you just ask them when it's on?
if it was something that was pertinent, so far, that wouldn't really be if it was something that this was that 3-week long thing, then I would want to ask if they had been to the doctor during those 3 weeks.
Okay,
But since this was, boom, I was just out doing it, and then now this is where we're at, I wouldn't ask that question.
okay.
But let's get back to the past medical history thing. If you ask somebody, hey, do you have any past medical history? 9, 10, well, not 9, 10, probably 6 out of 10 times, they're gonna say no. Because what's past medical history to them compared to what you think past medical history is? So the way I always ask past medical history is like, hey, do you have any heart problems, lung problems, diabetes, asthma? It's funny how people don't associate lung problems with asthma, right? Lung problems, asthma, cancers, seizure disorders, anything like that. And they're like, and then how about high blood pressure, right? Because high blood pressure is gonna tell me a lot with this patient. Same kind of thing with stroke patients. High blood pressure is gonna tell you stuff. Have you ever had seizures or strokes? So I wanna get very specific because those are things that are pertinent to what it is I got going on here, okay? And then if there's any sort of ports or anything like that, then I'm gonna ask about some of the renal stuff, if they have any But if you leave it out vague for them, they're gonna give you no as an answer. And you're like, oh, you get to the hospital, like, I've had a 5-way bypass, blah, 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 blah. You're like, didn't tell me a single thing. Or you'll show up at the hospital and that's when they throw out the, oh, I've had chest pain. After they didn't say chest pain one time, you had them.
Also, wear that like a badge of honor, like how many bypasses you had, they're like happy to tell you.
Yeah, so. Let's see, L,
Last intake.
last oral intake, is that important to us?
Yeah.
Yes.
Why?
So they ate 7 million cheeseburgers just before that, I can be their chest pain.
That's a lot of cheeseburgers.
Yeah.
I had a double bacon burger right before I would start mowing the lawn.
And if they need to do
Oh,
a
and,
procedure.
and also,
So do you guys think that something that they just ate is gonna affect, their cardiovascular system immediately?
No,
I like that regular.
it's a pack.
No, it's not. So, the last oral intake, that is only something if I feel like I'm gonna end up having to intubate this person. If I'm gonna have to manage their airway, or if they're going into surgery. This is not a question, I would say, out of 100 patients, I will ask what the last thing they ate was, probably less than 5 times. Because it really doesn't have a whole lot to do with what we're doing, or even what's going to happen immediately thereafter. There will be times where we're like, hey, can I get a drink of water? No, we're gonna hold off on letting you have anything, just in case you have to have
Well,
surgery, just in case.
In this case though, because you did on a nitro, you would wanna know, when was the last time you took your nitro pill?
Oh, absolutely, and that would be back in your medications,
Medication.
past medical history stuff, like, as soon as you dive into they tell you that they have nitro, you'd be like, okay, you got chest pain? Did you take it?
Right.
Right? How many should they take before they even call you? They're directed by their doctor to take 3, right? Do they always take 3? No. Half the time they don't take any, and they're like, hey, I got angina all the time, I got this nitro. It's like, oh, did you try it? And they're like, no. It's like, oh, well, hey, let's give you nitro. Boom, pain's gone. It's like, weird, huh? They give you this to do this, right? So last oral intake's not a huge important thing for us. And then our E,
Events leading up.
we've already covered the events, right? Basically, we've covered everything, events leading up to it. So, are we good here? We good on our chest pain?
Well, you wanted to go back to
You're right.
allergies.
Want to go back to allergies? Okay, let's go to allergies. Oh, later, don't really care about this yet, right? So now, boom, now we're back to it. When do we want to care about allergies?
You're gonna get meds.
Before we give anything, right? So until then, if somebody has chest pain, unless they're presenting with hives or wheezing or something like that, it's not something that we're really concerned about. But before you give anything, before you start an IV, before you do anything whatsoever, because people will have latex allergies, you want to make sure, boom, okay, your treatment has started, you're ready to make a treatment decision. Do you have any allergies? No. Okay, boom, all right, I'm gonna give you some fentanyl. Get my fentanyl all drawn up, get it all set, ready to go. I'm just like, so, double checking, you got no allergies to medications. Nope, nothing. I'm gonna give you a medication called fentanyl. Have you ever had it? Oh, yeah. Oh, yeah, what did it do for you? Oh, yeah, I threw up really bad last time. I was like, oh. Okay, is that an allergy? No. Adverse reaction? Maybe. Maybe just they gave it too fast kind of thing. But it's something like, before I give any medication, I even double check the exact medication I'm given. Have you ever had this? Right? Yeah, I got hives, you know, kind of like that respiratory steroid I was telling you guys about.
And you guys use iodine for cleaning the.
Now we use alcohol preps. We use iodine if you know it's going for a Dewey case.
For a duty
Same.
case.
Right.
That saved my bacon once. But, okay.
If they're.
If you
That's-
don't want it, why?
What?
Yeah,
Alcohol.
Oh, you wanna know?
You gotta tell us the story now.
Yeah.
So I can't really get into a lot of the specifics because it's a local tragedy, but long story short, Dewey, severe car accident, transported the Dewey person. It was a major crime scene investigation, but I've been through this before, and I've been asked by previous cops early in my career to be like, dude, if you ever have a Dewey case, never ever use an alcohol prep, because they will always try and use that as some way to throw out your blood draw, your IV stick. Because majority of the time, they'll just use your IV stick as the blood draw. Because they want the quickest, most rapid blood out of the person. Because, like, it's amazing, the cops will beat you to the hospital most of the time and be waiting, be like, the trauma surgeon's in there doing their thing, and they're like, we need blood, and they're like, yeah, just give us a minute, and like, they're on top, we need blood, we need that blood as soon as possible, because they know it's a major crime, investigation. So, I'm sitting there and I'm typing my chart up, and it's one of those charts that's gonna take you like 2 hours to do, because you wanna make sure all I's are dotted, T's are crossed. Cop comes in, he goes, hey, so you transfer to this person? I'm like, yep. He goes, so you started the IV? I go, yep. Because back then we actually did blood draws at the time too. And he goes, hey, did you do the blood draw? I'm like, yep. He goes, oh, okay. And so I knew what he was going for because I'd been there and done this with other cops before. And he goes, walk me through the steps of what you did. I'm like, oh, well, actually, I used, we had betadine swabs. I go, actually, so what I did is I used a betadine swab, and then I used a 4x4, and an aseptic technique, wiped that off, got that clean. He's like, so you didn't use an alcohol swab? I'm like, nope. Instantly, big old grin on his face. He goes, really? I go, yeah. He goes, is that standard practice? I was like, no. He's like, so why did you go with the betadine? I was like, because I've been asked by some of your colleagues in the past that if there was ever a Dewey case, to not use an alcohol thing because there was the potential that the defense could use that as an attempt to try and throw out your blood draw. So, long story short, so if I ever have a Dewey case, that's what I roll with.
I
So,
still don't understand what a Dewey case is.
DUI.
driving under the
DUI.
influence. Driving under the influence. Drunk driver got in a car
I looked
accident,
up
killed.
Dewey and there was like double homicide by someone
Yeah.
named Dewey. Okay, got it.
Nope, it's
All right.
DUII, driving under the influence.
Got it.
Intoxicants.
Can affect the blood alcohol content? Is that
No,
what
but it has the ability to be able for them to argue and say, oh, hey, it's a tainted sample, and so
It's
they.
possible, but they're not the same types of alcohol.
Exactly.
Right, and so
Nice
that's
approval.
where it gives them the ability to argue something in an attempt to get that stuff thrown out, so. So yeah, so.
So now, you all know not to use that in one of
Yeah,
those
so like
cases.
if you get drunk and you run into somebody, be like, oh, use an alcohol swab, please. Just kidding, you guys would never do that. Okay, so the one thing, here we go. So this last oral intake. So you don't really care about this that you ate unless they're vomiting blood, and the last thing they ate was red Jello. I kid you not. I went on like a 19-year-old kid, GI bleed, bright red blood. And we're sitting there, we're talking to this kid. He's like, yeah. He's like, I've been thrown up. It's like, it looks bad. It looks really bad. It's like bright red blood. He's like, I think I'm dying. I was like, yeah, I think you are too, man. If you're throwing up that much bright red blood, like, cause like he had this bowl full, and I'm just like, that is bright red. I'm just like, this guy is dying from the inside out. I was like, look bright, but yeah. I was like, and that's the thing is like, I'm sizing this kid up, and I'm like, he's not pale, he's not diaphoretic. I'm just like, this is not making sense. Like something's not. And so I just do like the old jaunt to the bathroom and be like, hey, I'm just gonna take a look at your toilet here and take a look, and yeah, bright red blood in there. And I just happened to, on the way back, be walking by the kitchen, I look in there and there's this box and bowl of like strawberry Jello. I was just like, oh yes. So I walk over there and I look, and I'm just like, yep, it's all made up, it's all ready to go. Looks like it was just like still just cold out of the fridge and everything. And I was just like,
Did you eat that?
so of course, me being me, I'm just like, so dude, I don't know if you're gonna make it, man. He's like, what? He's like, you are like actively bleeding. Like at this point, I double checked both things compared before I started this. And I made sure, yep, there's Jello here, there's Jello here. That's what he actually just threw up Jello. He binge ate Jello. And so I'm just like, yeah, I think you are bleeding out from the inside. I go, you know what we need to do? I think we should do surgery right here. He's like, really? I'm just like, yeah. I'm like, so I'm gonna send my partner out to get a scalpel, and we're just gonna have to slice you open, and we're gonna have to fix this now. Obviously, you can't do this with a lot. You gotta pick and choose who you do this with. He's like, okay, just save me, man, save me. Whatever you gotta do, save me. I'm like, okay, so this is what we're gonna do. And I walked over, I'm like, I grabbed the bowl of Jello, I'm just like, okay, so what I need you not to do is eat any more of this Jello. And I said it there, and he's like, okay, I won't. I promise, I'll never eat Jello ever again. I'm like, okay, because you're throwing up your Jello, bud. He's like, what? I'm like, you're not bleeding, you're totally fine. He's like, he does this thing, and he's just like, oh. I was just like, yeah, man, you're totally fine, you're gonna survive, you're good. He's just like, oh. He's like, I'm so sorry I called you guys, I'm such an idiot. I'm like, I didn't say, yes, you're an idiot, but it's all right, man. It's gonna give me something I can talk about for years now. I'm like, you will always be the Jello dude to me. And he's just like, all right, man, cool. I'm just like, all right, no more Jello for the rest of the day. All right, good dream. So,
You gotta eat.
yeah.
It's a lot of jello.
Okay, so, any questions on the chest pain stuff?
How concerned are you with, you've covered last in, but last out?
In relation to cardiac, I'm not real concerned with it.
Just relates to cardiac.
Yeah. Now, if it's an abdominal pain, if it's more one of those sketchy, maybe chest pain, maybe upper abdominal pain thing, then I'll get into some of the output stuff. All right. So, you guys totally good on running a cardiac chest pain call? Piece of cake, right?
Pie.
Okay. All right. Respiratory distress now. Oh, here we go. We can go 1,000 different directions. We got our OPQ or ST in our sample history, right? When and how did it start? Pertinent to us? When and how? Why?
It's just been getting
Talked about this
worse.
last time. Acute versus non-acute. Tells you what? Potential?
Chronic or
PE.
Sick, not sick. Well, I mean, even if it's a slow
Chronic.
onset, it's still sick. Because what do most COPD patients do? Are they used to being short of breath a little bit? So when do we get the call?
It's really
We're
bad.
way behind. Way behind. Okay? So you have to catch up. So when we're talking about the quick onset, so we go back to the PEs, right? Acute onset respiratory distress. Boom. It's an immediate emergency thing. Not a whole lot we can do for it. O2 IV monitor, rapid transport kind of thing. Thank you, Dr. Doherty. And then kind of the slower onset, that's your COPD, your bronchitis patients, your CHF patients. There are flash pulmonary edemas that are out there. It's very rare that you do see it, but when you do see it, just know that good luck. Good luck catching back up. Flash pulmonary edema is basically the immediate dump of fluids into the lungs. And it happens instantaneous, exertional, basically. From the time somebody's sitting there, they're a little short of breath, you stand them up, you walk them like to your gurney, and by the time they're to the gurney, they're drowning. You screwed up. Why'd you screw up?
Let them walk.
Exertional, boom. So, what you'll probably know, and what you'll probably in retroactively look at it, and be like, oh, this patient was on Lanecc, this patient has a history of congestive heart failure. I should have picked up on that because I know I'm supposed to look at meds and history and catch all that stuff. And so you'd be like, oh, I really screwed that one up. So that's why, for me, I like to get the whole picture before I make any sort of determination on what I'm going to do, what route I'm going to treat, and that kind of thing. So, how long you been dealing with it? That's where the chronic people, chronic COPDers, they wait and wait and wait and wait and wait, probably 2 to 3 days of buildup. Is this chronic or not? Chronic being like, are they being treated? Do they see the doctor? A lot of times these chronic patients, what kind of medication are they on? Yes. Usually they're on some sort of steroid in an attempt to help, okay? And a lot of times they've been like, hey, I just finished up my steroid dosing and I was good for a day and now we're back again. So what they're gonna do is they're gonna go back on steroids probably for another week or so, maybe 2, to help with that. Here we go. If I got somebody that has shortness of breath, you walk through the door and you say, I can't breathe, I'm having a hard time breathing. This is where, once again, my first question is do you have chest pain? Okay? Because if I have chest pain, what do I immediately, if you're having a hard time breathing, and I say, hey, do you have chest pain? What do I immediately do?
Go down the cardiac.
I jump right back over here to the cardiac, okay? And I run through my entire cardiac, all right? Because majority of the time, the cardiac is what is causing the respiratory issue, all right? And if you fix that, you fix the respiratory issue, okay? A lot of times it's a rate-related thing, chest pain, and so just that tactic differently. We talked about orthopnea the other day, right? Laying down. What's that tell us?
They got fluid in the lungs.
Fluid, okay. Cough production. Cough, what's the cough in production? What are we looking for there?
Like coughing up.
The bright red blood.
So what happens if I say I got green stuff?
Pneumonia or infection.
Does that mean I have an infection? Maybe
You
it's just
need
always-
anything green lately?
There we go. Hello,
I
eh?
get green jello.
So most of the time, you're looking at, yeah, is this a bronchitis? Is this a generalized cold? If it starts to turn color, then we start working pneumonia. Fluid production, I mean, you could be congestive heart failure, pink frothy sputum. So you have a multitude of different things that you're gonna start to rule out based on what that sputum starts to look like and how much production there is. When it comes to this, you wanna always make sure you check temp anytime you're trying to rule out pneumonia versus congestive heart failure. Because a lot of times that temp, as long as you're not septic, a lot of times that temp will tell you that it's pneumonia versus congestive heart failure.
If they're coughing up green or yellow stuff and they've got, 100 on temp, it's pneumonia, right?
Well, not 100% of the time, but your index of suspicion is high that it's pneumonia, yes. How additionally are you going to be able to help? What additional things will you use to help lead you down the pneumonia path? Okay, and what would you expect with pneumonia?
Would be absence or some
Okay, get a little more specific.
wet.
Okay, a little more specific. Keep going.
Maybe.
A lot of times pneumonia, do you usually get pneumonia in both lungs or one a lot of the time?
One.
Usually you have pneumonia and it's a unilateral, and that's a lot of times that will help you with the